Potassium imbalance. Introduction. Potassium, K*, is the major intracellular electrolyte. In fact, 98% of the body's potassium is inside the cells. The remaining 2% is in the ECF and is important in neuromuscular function. Potassium influences both skeletal and cardiac muscle activity. For example, alterations in its concentration change myocardial irritability and rhythm. Under the influence of the sodium-potassium pump, potassium is constantly moving in and out of cells. The normal serum potassium concentration ranges from 3.5 to milliequivalent/L, 3.5 to 5 millimoles per liter. Potassium imbalance is divided into two. Potassium deficit, hypokalemic. Potassium excess, hyperkalemia. Potassium deficit, hypokalemic. Hypokalemia, serum potassium level below 3.5 milliequivalent/L, 3.5 millimoles per liter, usually indicates a deficit in total potassium stores. However, it may occur in patients with normal potassium stores. When alkalosis is present, a temporary shift of serum potassium into the cells occurs. Pathophysiology. Medication-induced hypokalemia. Potassium-losing diuretics, e.g., thiazides, loop diuretics, cause potassium depletion. Other medications include corticosteroids, sodium penicillin, carbenicillin, and amphotericin B. Gastrointestinal losses. Vomiting and gastric suction lead to hypokalemia by direct potassium loss through gastric fluids. Potassium loss via kidneys in response to metabolic alkalosis. Diarrhea, containing up to 30 milliequivalent/L of potassium, is a major cause. Prolonged intestinal suctioning, ileostomy, or villus adenoma also contribute to potassium depletion. Acid-base imbalance. Alkalosis, respiratory or metabolic, causes transcellular potassium shifts, hydrogen ions exit cells, and potassium enters to maintain neutrality. 4. Hormonal effects. Hyperaldosteronism. Primary, adrenal adenomas. Secondary, cirrhosis, nephrotic syndrome, heart failure, malignant hypertension. 5. Insulin effects. Insulin drives potassium into skeletal muscle and liver cells. Persistent insulin hypersecretion, e.g., high carbohydrate parenteral nutrition, can lead to hypokalemia. 6. Dietary deficiencies. Poor intake due to aging, alcoholism, or anorexia nervosa. Bulimia contributes via vomiting, laxative, diuretic, or enema misuse. 7. Magnesium depletion. Causes renal potassium loss. Magnesium correction is essential to prevent ongoing potassium loss. Clinical manifestations. Neuromuscular symptoms. Muscle weakness and cramps. Paresthesia, tingling or numbness. Paralysis in severe cases. Cardiac symptoms. Arrhythmias, e.g., premature ventricular contractions, ventricular tachycardia. Electrocardiogram, ECG, changes, flattened T waves, prominent U waves, and ST segment depression. Gastrointestinal symptoms. Constipation. Abdominal distension. Ileus due to reduced gastrointestinal motility. Renal symptoms. Polyuria, excessive urine production. Nocturia, frequent urination at night. Inability to concentrate urine. Metabolic symptoms. Glucose intolerance due to impaired insulin secretion. Central nervous system symptoms. Fatigue and lethargy. Mental confusion or irritability. Respiratory symptoms. Weakness of respiratory muscles, leading to shallow breathing in severe cases. Diagnostic test and assessment. Serum potassium level. Primary diagnostic test, normal range, 3.5 to 5.0 milliequivalent/L. Hypokalemia is diagnosed when levels fall below 3.5 milliequivalent/L. Arterial blood gas, ABG, analysis. Evaluates acid-base imbalances, e.g., metabolic alkalosis, contributing to hypokalemia. Electrocardiogram, ECG. Identifies cardiac effects of hypokalemia, such as flattened T waves. Presence of U waves. ST segment depression. Arrhythmias like ventricular tachycardia or fibrillation. Urinary potassium excretion. Determines renal potassium loss, normal urinary potassium, 25 to 125 milliequivalent/day. High urinary potassium suggests renal causes, while low levels suggest extrarenal loss, e.g., diarrhea. Magnesium levels. Hypomagnesemia may coexist with hypokalemia and exacerbate potassium loss. Renal function tests. Includes blood urea nitrogen, BUN, and creatinine to assess kidney function in potassium excretion. Dietary and clinical history. Assesses intake, vomiting, diarrhea, or use of diuretics and other medications. 24-hour urine collection. Provides a comprehensive evaluation of potassium loss over time. Medical management. Potassium replacement. Oral supplements, for mild to moderate hypokalemia. Examples include potassium chloride tablets or solutions. For potassium, reserved for severe cases or patients unable to tolerate oral potassium. Administer cautiously, typically diluted and infused slowly to avoid complications like arrhythmias. Address underlying causes. Treat gastrointestinal losses, e.g., vomiting, diarrhea. Adjust or discontinue medications contributing to hypokalemia, such as diuretics or corticosteroids. Dietary interventions. Encourage potassium-rich foods like bananas, oranges, spinach, potatoes, and tomatoes. Magnesium repletion. Correct coexisting magnesium deficiency to prevent continued potassium loss through the kidneys. Monitor serum potassium levels. Regular monitoring to ensure effective correction and avoid hyperkalemia. Adjust diuretic therapy. Switch to potassium-sparing diuretics, e.g., spironolactone, amiloride, when appropriate. Manage acid-base imbalance. Address underlying metabolic alkalosis or other acid-base disturbances. Patient education. Teach patients about hypokalemia symptoms and the importance of adhering to dietary and medication guidelines. Assessment and monitoring. Monitor serum potassium levels regularly. Observe for clinical signs of hypokalemia, e.g., muscle weakness, fatigue, arrhythmias. Monitor cardiac status using ECG for arrhythmias. Check for signs of metabolic alkalosis or acid-base imbalances. Administration of potassium. Administer prescribed potassium supplements, oral or 4, as directed. Ensure 4 potassium is diluted and infused slowly to prevent irritation and hyperkalemia. Monitor infusion site for signs of phlebitis or infiltration during 4 administration. Dietary guidance. Educate patients on incorporating potassium-rich foods, e.g., bananas, oranges, spinach, into their diet. Collaborate with a dietitian for personalized meal planning. Manage underlying causes. Address contributing factors like vomiting, diarrhea, or medication use. Report excessive gastrointestinal losses or medication effects to the physician promptly. Education and support. Teach patients to recognize early symptoms of hypokalemia, such as muscle cramps or irregular heartbeats. Provide guidance on medication adherence and lifestyle changes to prevent recurrence. Magnesium and acid-base balance. Monitor and correct magnesium levels as needed to support potassium retention. Assist in managing metabolic alkalosis if present. Document and communicate. Record all interventions, patient responses, and lab results accurately. Communicate with the healthcare team regarding changes in the patient's condition. Pathophysiology. Decreased renal excretion. Renal failure compromises potassium regulation, particularly with a glomerular filtration rate less than 10% to 20%. Hypoaldosteronism and Addison's disease lead to sodium loss and potassium retention. Potassium shift, ICF to ECF. Acidosis promotes potassium efflux as hydrogen ions move into cells to buffer pH. Extensive tissue trauma, burns, crush injuries, or tumor lysis syndrome after chemotherapy causes cellular potassium release. Excessive potassium intake. Rapid potassium administration or improper use of supplements predisposes patients, especially those on potassium-conserving diuretics or salt substitutes. Medication-induced. Contributing drugs include ACE inhibitors, NSAIDs, beta blockers, potassium-sparing diuretics, heparin, and immunosuppressants, e.g., cyclosporin, tacrolimus. Pseudohyperkalemia. Results from sample mishandling, hemolysis, or blood drawn near potassium infusion. Marked leukocytosis or thrombocytosis can cause false readings, necessitating retesting. Cardiovascular symptoms. Bradycardia, hypotension. ECG changes, peaked T waves, prolonged PR interval, widened QRS complex, ventricular fibrillation, or asystole. Neuromuscular symptoms. Muscle weakness, starting in lower extremities and progressing to flaccid paralysis. Paresthesias, numbness or tingling sensations. Gastrointestinal symptoms. Nausea, vomiting. Abdominal cramping and diarrhea due to increased smooth muscle excitability. Severe manifestations. Respiratory muscle paralysis in extreme cases. Cardiac arrest if potassium levels are critically high. Subclinical signs. May remain asymptomatic in mild hyperkalemia, detected only via laboratory tests. Diagnostic test and assessment. Laboratory tests. Serum potassium levels, elevated, greater than 5.0 milliequivalent/L. Arterial blood gas, ABG, to assess acidosis, which can contribute to potassium elevation. Renal function tests, elevated creatinine and blood urea nitrogen, BUN, indicate impaired renal clearance. Blood glucose levels, to evaluate hyperglycemia, which may affect potassium regulation. Electrocardiogram, ECG. Peaked T waves, prolonged PR interval, widened QRS complex, or arrhythmias suggest hypokalemia-related cardiac effects. Urine analysis. Low urinary potassium excretion may indicate renal failure or hypoaldosteronism. Pseudohyperkalemia assessment. Retest serum potassium if hemolysis, thrombocytosis, leukocytosis, or mishandling of blood samples is suspected. Clinical history. Assess medication use, ACE inhibitors, potassium-sparing diuretics, etc., dietary potassium intake, and underlying conditions, e.g., renal failure, Addison's disease. Physical examination. Monitor for muscle weakness, hypotension, or signs of cardiac instability. Stabilizing the myocardium. Calcium gluconate or calcium chloride, administered to stabilize cardiac membranes and reduce the risk of arrhythmias. Shifting potassium into cells. Insulin with dextrose promotes cellular uptake of potassium, preventing hypoglycemia. Sodium bicarbonate, used in metabolic acidosis to correct pH and facilitate potassium shift into cells. Beta-2 agonists, e.g., albuterol, enhances cellular uptake of potassium. Removing excess potassium. Diuretics, loop or thiazide diuretics to promote potassium excretion. Sodium polystyrene sulfonate, K-exolate, facilitates potassium removal via the gastrointestinal tract. Hemodialysis, for severe hyperkalemia or renal failure patients when other measures are insufficient. Addressing underlying causes. Discontinue potassium-sparing medications, e.g., ACE inhibitors, NSAIDs. Treat acidosis, infections, or other precipitating factors. Monitoring. Continuous ECG monitoring for cardiac arrhythmias, regularly reassess serum potassium levels and renal function. Nursing management. Assessment and monitoring. Monitor vital signs, focusing on heart rate and blood pressure. Continuously assess for ECG changes, peaked T waves, widened QRS. Monitor serum potassium levels and other relevant lab values, e.g., renal function, ABG. Assess for neuromuscular symptoms like muscle weakness or paresthesia. Administering medications. Administer prescribed medications like calcium gluconate, insulin with dextrose, or sodium bicarbonate. Ensure proper dosing and timing of potassium-binding resins, e.g., K-exolate. Assist with preparation for dialysis if required. Dietary management. Educate on a low-potassium diet, avoiding foods like bananas, oranges, potatoes, and spinach. Advise against the use of salt substitutes containing potassium. Fluid management. Maintain adequate hydration to support renal function and potassium excretion. Administer 4 fluids if prescribed to prevent dehydration or improve perfusion. Patient education. Teach the patient and family about the causes and prevention of hyperkalemia. Provide instructions on medication compliance, especially avoiding potassium-sparing diuretics if not needed. Emergency preparedness. Be prepared to manage complications like cardiac arrhythmias or respiratory muscle paralysis. Ensure emergency equipment, defibrillator, is readily available. Collaboration. Work with the healthcare team to address underlying causes, e.g., acidosis, renal failure. Communicate changes in the patient's condition promptly to the physician.